much. I hope you can hear me. Thank you very much for inviting me to this interesting session. Can you hear me?
Yes, Dr. Tan.
Okay, good. So I was asked to talk about the Endoglide. And obviously here my financial disclosures. Network Medical Product makes the Endoglide. So if we look at my PK to DSEK evolution quite some time ago, of course, when we were talking about PK, we looked at our results, and our first year endothelial cell loss was about 40%. And then this exciting new procedure, DSAEK, came on board. And we started to do that, and I typically used the technique. And the taco folding, we ended up with more loss, 60%. And these were in Asian eyes. This was back in 2006. We then devised the Sheets Glide, and I was very interested to hear that the Sheets Glide seems to be the most popular. Of course, it's very low cost, and able to halve the endothelial cell loss from 60% to about 30%. But of course, there were challenges with this as well. And so in 2009, we came out with the Endoglide, which was a disposable inserter, and that showed a 15% cell loss. So we've managed to halve our endothelial cell loss during each insertion transition. So I think for DSEK, it's all about, well, at least the most important point is reducing endothelial cell loss. And I think it's all about control and manipulation. So successful DSEK results in a high cell count and low primary graft failure. And I think it's all about achieving control of the donor. That's why DMEK, for example, is so difficult. But also the control of the anterior chamber. I mean, we only have to use BSS and air only. And I think the main challenging stages are donor insertion, donor manipulation, and this is where both the donor and the AC is crucial in both. And therefore, selecting the right technique provides the best control. So we're talking about DSEK, but for DMEK, I think this becomes even more important. So back in, we launched the Endoglide back in 2009, the first version. It was an FDA Class 1 device with CE mark. It's made in the UK by Network Medical. And we quickly were very pleased to find out that it has actually a very low endothelial cell loss rate, about 15% at 1 year. For more complex cases, it can go up to 27 to 30%. I think it's available now in many countries. It's limited in use perhaps because of the cost being a disposable inserter. We've got about 10 years follow-up already. So this was the first version, what they call the classic. This is no longer available. The design was really to make it fairly idiot-proof. The design concept was simplicity. It's like putting a thumb drive in a USB port, and the donor lies coiled up endothelium in this chamber. It's now available in 2 versions. The standard DSEK instrument is called the Endoglide Ultra Thin. It was redesigned for ultra thin DSEK as well as for normal DSEK. And of course, now we have the DMEK version, the DMEK Endoglide. And the difference really is the cartridge, and it's just lost weight. It's become skinnier. The DSEK ultra thin cartridge goes through a 4.5 to 4.9 millimeter incision, and the DMEK through a 2.7 millimeter incision, obviously because the donor is much narrower now. These forceps are probably one of the most useful instruments. I use them for everything. The straight loading forceps is used to load the cartridge with the donor. And this curved insertion forceps is very useful. I use it to suture inside the eye, to hold iris, to remove endothelial tags, etc. So why is control better? I think the first thing is that unlike some of the other inserters, or the Sheets Glide for that matter, there is a sealed chamber throughout in this dotted area. So with an AC maintainer on low flow, actually the chamber is well filled and there is no fluid movement. So you have good control of the anterior chamber. At the same time, with the pull-through technique, you are having full donor control as well. So this is useful in cases which are more challenging, small eyes, high vitreous pressure, glaucoma cases, etc. We started off with the first series of the first 25 eyes, and we had about a 15% cell loss. We then went to a 100 eye study with 5 surgeons. We got about the same cell loss, about 15%. And then we looked at complex cases, and the cell loss at 6 months, about 18%, and at 12 months, about 27%. So here's the basic technique here. I've already pre-separated the donor lenticule a little bit. We've put fluid in the, this is the ultra thin DSEK. This is BSS in the chamber. We try and make sure there's no air bubble. And we're just carefully manipulating the donor. This is, of course, endothelial cell up. And I'm pushing it towards the edge of the cartridge, the opening there. And you'll see on the left, the wet cell sponge is used just to wick fluid. And this really helps. It's not essential, but if you look very carefully at the donor, as fluid goes through, the donor starts to go in. And so it actually starts to coil. These edges are coiling up. That starts the coiling process. You then use the straight, so a little amount of viscoelastic, just a tiny amount, probably optional. And here the straight loading forceps, you grip the tissue. And interesting tip I always tell my residents is that, look at it, I'm waving it up, and as I do that, from side to side, the edges coil up. So it coils the right way. We stop right about there. Now this tissue, this is completely upside down. You need to remember that, and I'll show you in a while. So when we take off the saddle and we put on the back end, this is the handle which seals. It says loading. And then the other side is insertion. So once you take this out, you have to flip it the right way around. And this is the glide going in. This goes through a scleral wound. You can do it through a corneal wound as well. This is the first stage where you don't lose the AC. There is a transient risk of iris prolapse, but you quickly push it through. This wound has to be reasonably tight fit, not too tight, because you have to retract the donor, the cartridge after that. And then through a nasal paracentesis, this is the insertion forceps. You grip the tissue, pull it in. The AC maintainer is on low flow at this point, and whilst holding onto the donor, you retract the cartridge. The wound closes, the AC deepens, and then you can do a little bit of manipulation, just a bit of tapping, and the donor should unfold. And you notice this patient has got 2 tubes here, so not a standard patient by any means. And whilst you're still holding on, don't let go of the donor. Put in some air, and then you suture. I've already sutured the wound here, and then finally a full air fill. And a little tip, I always put we tend to use venting incisions, and you'll see that these venting incisions here, I'm using a Sinski just to wick away the fluid for the full air fill. In this case, a full air fill, this is how this patient did. So when we looked at our studies, this is PK, the cornea donor study, PK endothelial cell loss at 1 year. This is Bond's PK study. And you see this quite a sharp drop in the endothelial cell density after surgery at 1 year. This is DSEK by Mark Terry, Frank Price, and very similar. There is an initial steep drop, and this is the surgical loss due to the initial surgical loss of cells. Here's the endoglide, and you see that that curve is a little bit less steep. So we think we've eliminated that initial steep drop due to surgical trauma. This is a study which we did. We compared the Sheets glide to the Endoglide. Actually, we were pretty happy with the Sheets glide initially. The cell survival the graft survival is good, but the Sheets glide is slightly inferior to the Endoglide. So we are getting about 16% cell loss at 1 year compared to 30% there. And at 3 years, about 30% with the Endoglide compared to about 38% with the Sheets glide. Here's a study done in the UK comparing the Busin to the Endoglide. They had slightly higher cell loss rates overall. I think I explained that. But the 6-month cell loss with the Endoglide was about 25% and the Busin 47%. However, because they're using organ culture, they say you have to exclude 8% extra cell loss. So once you remove 8% from these figures, then you'll see that the Endoglide is about 18% and the Busin glide 39%. So that's comparable to our results with the Endoglide. So I think the Endoglide technique offers greater donor control with a pull-through approach using the Endoglide forceps. The device, when used with a low-flow AC maintainer, enables enhanced control of the anterior chamber during donor insertion and manipulation. This approach results in lower endothelial cell loss than some of the other insertion techniques and allows for a more predictable surgical outcome, perhaps even in more challenging cases. What's interesting also is that once you learn this technique, then this certainly applies to DSEK. So with the new DSEK Endoglide now, we can use the same techniques that you use with the Endoglide DSEK ultra thin device and use this to perform DSEK. Thank you very much.